Well, thanks so much. Thank you so much, everyone, for joining. Like she said, I'm Erin Connor, and I'm going to talk to you today about some of the barriers that we face when we're trying to do communication between CPS and healthcare systems. I'm going to tell you some about our integrated care clinic here in Dallas and what we have done to address those barriers. So let's get started. Okay, so first off, I have a question, and I want to know what the barriers are that you faced when trying to communicate between CPS and healthcare systems. So if you want to put your response in the chat box, and they're going to read them out loud. We'll take just a couple of seconds on that. Esther, can you read those out loud for me?
Well, so far I see making contact, telephone tag, privacy.
Yeah, that's good. Those are all things we're going to talk about. And if you have additional questions after I'm finished, we can definitely address those specifically. But we're going to talk a little bit about both of those things as we go through.
There's another one, time frame.
Okay, great. Yeah, we're going to talk about that as well. So here are our objectives today. We're going to talk about what we have found in our clinic to be the most common barriers between CPS and healthcare. The role of the healthcare liaison, which is my role, and how we've improved communication between CPS and our center through my role. And we're going to talk more about the successful ways that our center has found to work through those barriers and alongside CPS and other community partners and collaborate towards those successful outcomes that we're all hoping for. So today we have more ways to communicate than ever before, but communication across systems is still a major issue. Lack or miscommunication of these and these barriers often add frustrations to what can already be high-stakes circumstances. So this is especially true when we're talking about the child welfare system. As we all know that the child welfare system is not super advanced in technologies and things like that. So this lack of communication can lead to more issues when we're trying to help children who are in foster care or involved in the foster care system. So one major way.
Erin, we cannot see you. Did you stop the video?
Oh. No, sorry.
Oh, now we can see you. Thank you.
Yeah, good. So one major way that this can impact working with these children is in the child's history. So that can include their trauma history, what they've been through, what they've been exposed to, their educational history, what their grade level is, what if they're in special education classes or if they have any sort of accommodations, their medical history, diagnosis with both mental health and medical, and then also their behavioral health. So what are their behaviors, medications, things like that. So if any of that information is missing, you're not able to treat the full child because you're missing what could be an invaluable piece of why they're having those behaviors, why they're struggling in school, what environment are they coming from that's causing these behaviors. So all of that kind of adds up to creating bigger issues when you're trying to treat the child. Family history, same thing. If you don't know that what mom and dad have been through, or you don't know what their diagnoses are, then you're not going to be able to treat the child fully. And permanency goals. When working with CPS, you want to know what their plan is. What are they working towards? Is the child moving soon? Okay, that gives us a different idea of what we're working with than if we're going to be treating the child for the next year or two. So those are just a few things that can happen to cause issues. Come on, there we go. So here are the issues that can arise when we're siloing efforts when we're all working in the child welfare system. So that can include CPS staying on their side, not communicating with medical doing their thing, not communicating with CPS. So everyone has good intentions and everyone is doing their job to the best of their abilities, but there's a lot of that in-between space that can be used to fully treat the child and make sure that nothing gets missed. So those are a few things we're going to talk about now. One of those issues that can come up is when you have multiple people working on the same task. So if the caseworker is working very hard to make sure that the child's needs are met at school, but then you have healthcare providers who are also working to make sure their needs are being met at school, that's going to create a jumble of information for the school, and that's going to cause delays. So we're going to talk more about that. It's also a waste of resources. You know, working in government and medical agencies, we're used to having to be resourceful, but if you're using too many papers, computers, gas, just those tangible things, but also your time and energy that you're putting in taking care of these kids, that's going to cause a delay in the services, as I mentioned, especially when there's insurance involved. A huge example of this is therapies. So same thing, if you have the caseworker trying to set up therapy, this is something we run into all the time in our clinic. If the caseworker is trying to set up therapy, but then the medical team is also trying to set up therapy, you may have two different therapists working on the same child and treating the same child, contacting the caregivers, trying to make appointments, and then you have a caregiver who's got two therapists coming to the house, whatever, when they're all working on the same issues, and that doesn't necessarily need to be the case. So that's a huge way that we see that come up. Same with insurance. You know, we've all heard of patients who said they didn't qualify for services because they've reached their limit of hours or, you know, their time or whatever, when really it just hasn't been brought by the right person and the right words. So that's another way, you know, when people aren't communicating, working together, that can happen. So ultimately it hinders progress and more resources have to be used to solve it. Inaccurate information, same as I kind of mentioned before, leads to delays in services, procedures, meetings, evaluations, the list goes on and on. In our clinic, a perfect example of this is we had a child come in, she'd been in care for a while and she was diagnosed with leukemia. So one of our providers was going through all the paperwork, all the records from the hospital that previously treated the child, doing all of this, you know, digging to try to find where this diagnosis came from. CPS didn't have the records going through. It was just being passed on paper when really no one had actually done testing. The child was medically complex. So lots of things were getting delayed because of this leukemia diagnosis, but the child ended up not actually having leukemia. It had just been kind of mentioned in passing one time. So because our team was able to do some digging and really look at that and not just pass it off, it was able to progress and help some things. But that's an example of inaccurate information being passed on because the right questions weren't asked. So on the same note, this could be potentially harmful and cause a child to relive trauma when children and families have to, you know, rehash information that they've already given, or, you know, children are interviewed when they first get involved with the child welfare system. If they have to do that interview all over again when they see their provider, when they're talking to CPS and they have to tell their story over and over, they're having to relive that, and that's not good. So if there was communication between the systems, that would eliminate that need for them to retell their story. And it just doesn't allow for you to address needs. If you don't have all the information in any, area of life, you can't take care of business. And that's especially true in the child welfare system. So another example is, important voices get left out of the conversation. So if you're not making that extra effort to talk to everyone, you don't have everyone's input. So within the child welfare system, working with CPS, there are multiple caseworkers. There can be the primary worker, there can be a kinship worker, there can be an out-of-region worker. And that's just for one child. So you want to make sure that all those people who are having those conversations with the family as well, you want to make sure everyone has input, because pieces can get left out, and that goes back to that lack of information. That can lead to disconnect between the agencies. If everyone doesn't have the information, someone gets left out, they're not included in that conversation. They're not going to be as connected to working towards that positive outcome. And again, this can also cause delay in services and missing some of those needs, which is the next slide. So needs ultimately just get missed. If you're not having those conversations, if you're not having all those records and listening to everyone who's involved in that case, on the provider side and the CPS side, needs are going to get missed. So because people keep their separate efforts and conversations, needs big and small go missed or unaddressed. And this also includes closing the loop to make sure, if you have that conversation, making sure that those things that you discuss actually get taken care of. A big example of this is medical equipment during placement changes. Placement changes happen even for our medically complex kids, but in the CPS system, at least in Texas, they have a staffing where they discuss, okay, this child has a bed, they have an oxygen machine, they have all these things, but then on the other end, after the child moves, no one is checking to make sure that all of that child's equipment, which has been paid for by their insurance, is following them to their next placement. This is something that our clinic is working on, but right now this is a major flaw, because we have caregivers who are getting these medically complex kids placed with them, and they don't have a bed, or they don't have a shower chair, or all these things that the children need to be safe in that home. So our clinic works closely with CPS to try to address those needs quickly, but it could be addressed early on in that initial meeting, and then maybe right after placement to make sure that that doesn't happen. So again, also causes misuse and waste of resources. Like I said, this meeting's already happening, so that's something that could be addressed in that meeting, that we're hoping that working with some of the state office staff, that we can kind of get that changed a little bit. So same thing, without having these conversations to address those needs, those needs you don't know about, there's a lot of resources that go unused. Sometimes people have donations of things, there's all sorts of community agencies that want to help, thank goodness. But if we're not talking about what the needs are, then you don't know to go ask. So that's another way that those needs can get missed. That's what happened, doubled up on that one. So now I'm going to tell you a little bit about our foster care clinic and how my position and the foster care clinic in general has a unique role in working with CPS to eliminate some of those barriers to communication. So the Rees-Jones Center for Foster Care Excellence is at Children's Health in Dallas and Plano. The Plano campus has had a dedicated foster care clinic since 2009. I believe the Dallas campus opened in 2011. Last year, we had over 7,800 patient visits annually between both locations, and I believe that's a little over 2,000 unique patients, so 7,800 visits total. We provide integrated care that's medical and behavioral health. So when the families come see us at the clinic, they see both the medical provider and behavioral health. So that can be a therapist, early childhood, psychologist, whoever is best fit for that child. And we serve children who are involved in the foster care system, whether that's they just have been removed from their home, they've been placed with a relative, or we stick with them all the way through permanency. So we see children, if a grandparent gets permanent custody, we're able to continue seeing them. But when a child is in their adoptive home, we try to transition them to other community providers. So now I'm going to show you a little video about our clinic that tells more and will explain some more about our unique position. So just a second, let me switch over.
The Rees-Jones Center for Foster Care Excellence brings together experts in pediatrics, mental health, and child welfare.
In the U.S., about 440,000 children are in foster care.
We are the only dedicated primary health home for children in foster care in North Texas.
Children in foster care oftentimes have experienced trauma. So we have what's called adverse childhood experiences, which includes things like abuse, it includes things like neglect, also other environmental challenges. So that can include things like divorce, incarceration of a relative. It can include violence towards a mother. These kinds of things are considered traumatic stressors for children, which can then impact health outcomes. 50% of kids coming into foster care have some sort of chronic health related illness. In terms of mental health related needs, we see a lot of trauma, so post-traumatic stress disorder is a pretty common diagnosis. We also see a lot of depression, anxiety. Many of the younger kids coming in have pretty significant developmental delays, which later impact their mental health functioning. Our center is a trauma-informed center. We understand the impact of trauma on a person, on a family, and on a system. Our team is trained specifically to manage trauma all the way from the front desk, all the way back to the clinical providers. Integrated care in our model at the Rees-Jones Center for Foster Care Excellence, we offer on-site collaborative care. So we have two providers in the room at the same time. So we have a mental health professional along with a medical professional working together to help coordinate care for our kids. So it's joint treatment planning.
So when a child comes in for their first integrated visit, they will see, depending on age, an early childhood specialist or a therapist, as well as a medical provider, and often the CPS liaison, who is our embedded liaison with the child welfare system, will also be involved in that visit. We'll see the child, do the kind of typical pediatric services, but in addition to that, the caregiver will have a chance to talk about any behavioral or mental health concerns that they have about the child, any developmental delays that they're noticing.
How is his behavior overall?
Overall, it's good. Saying no is the hardest part.
After the visit, all of us will come together and talk about, what do we feel this child needs? What is their individualized treatment plan as a whole child, addressing both, like I say, their mental health and medical problems.
Well, the idea is that the more persons who surround a child in foster care, the better outcomes that we would get for these children.
What we know about integrated care is it reduces healthcare costs overall over time. We also know that it's better coordination of services.
As someone who's practiced in both a more kind of typical pediatric setting and in the integrated health model, I really can see the difference that this makes for children.
I think the biggest service that we offer is just making sure the families get connected to the supports, and whether it be in our center or providers out in the community, we make sure that those families are aware of what's out there, and we can't do that in a 15-minute visit.
Okay. It's so good to see faces because I haven't seen a lot of those people in a long time, so it's nice to share that. So that's just a brief video that kind of introduces our clinic. Let me make sure I'm sharing the right screen. There we go. And tells a little bit more about the unique atmosphere we have to collaborate with CPS and community partners and have those conversations to remove those barriers that we're talking about. So now I'm going to tell you a little bit about my role and how, again, this unique position helps communication go smoothly. So a CPS liaison, I'm employed by the Department of Family and Protective Services. It's the name for CPS here in Texas, and I'm housed at the foster care clinic. I do not have a caseload, so I'm not an active field worker. I'm available during the day, and I'm not a replacement for a hospital social worker. Hospital social workers, we work very closely with them, and they have a lot more resources and access to things under the hospital social work department, so we always refer people to them, even though I can serve a similar role, but they're more equipped to handle some of the cases, especially involved in other clinics. So my role in the foster care clinic, I provide support to families and the providers to be a bridge between healthcare and CPS. So I provide feedback to CPS when needed. That can be concerns, recommendations, whatever the provider thinks will be beneficial to the case, whether that's medication, therapy, whatever that looks like. I can talk to CPS to make sure they have that information, because CPS also needs that information for their court reports, for their records, for their caregivers to share with CASA, attorneys, whoever. We want to make sure everyone is on the same page, and so I can share that information back and forth. Obtain information from CPS. You know, if we have a child showing some concerning behaviors or something like that, I can get the information from the caseworker of like, hey, foster mom said this or aunt said this, and get some more information to help the behavioral health and the medical team make those decisions for the child's treatment plan. And then just ongoing feedback, making sure that we keep track as best we can to those placement changes in permanency. So if a case closes, if a child moves out of this area, we try to connect with those caregivers and make sure that they have what we call a transition letter, which includes all the information of how they were treated and recommendations from their time at the clinic. And that happens whether we saw them one time for that initial visit or if we've been treating them for years. So those are really helpful to the next caregiver and the next providers. So I also gather documentation focused on the child's history. So part of that is I still have access to the CPS system. So I'm able to go in and get information from the case and put it into the hospital system as related to the child's needs and what they've been through. So that way it kind of goes back to what we discussed before about the child doesn't have to relive all that and tell the providers, tell the caregivers what they've been through. In some cases, I do share information with the foster parents. If, you know, the child, they got dropped off at 3 o'clock in the morning, they don't have a lot of information, I can, you know, go to the foster parent and say, well, they came into care because of this. And that also gives the foster parent some more information. So that's a big part of what I do. And then also reaching out to CPS for records. For psychologicals is a big one because those take a lot of time and kids are only eligible for those once a year. So we're able to request all those records from CPS directly, and so that our providers can use that. And that's a huge part of what I do, because we know that kids and caregivers aren't always the best historians when it comes to trauma, diagnosis, things like that. So we want to make sure we have accurate records, and that if we can't get them from CPS, we want to work with CPS to make sure we can get them from the right people. So these are a couple of examples of how I work within the foster care system. So one big thing that I kind of miss doing since I've been working from home is talking with first-time foster parents and kinship caregivers to explain CPS. So if you don't immerse yourself in this language every day like we do, it's a whole new world. It's very confusing. It can be very overwhelming. So I really enjoy being able to talk to the foster parents and kinship caregivers to make sure if they have any questions that they haven't been able to ask, that sometimes they're more comfortable asking me because I'm not assigned to the case at all. I'm not there for judgment in any way. I don't have any say in the case at all. So sometimes they ask me a little more openly than they might their caseworker or case manager. So that's something that I'm able to do within the clinic. Helping hospital staff within other areas of the hospital, making sure that if their kids move, that we can track them down to make sure they have those follow-up appointments as needed. Also to make sure with medical consent that they can get in touch with the caseworker. We know caseworkers can change a lot, so we want to make sure that that accurate person is able to get in touch with the right clinic. Talking with bio parents to explain the clinic. You know, we love when bio parents come in if they're working toward reunification or if the children have been placed with them on what is called monitor return here in Texas. We welcome them and we would love to work with them because those parents are going to need that extra support and to get that history of what the child has been treated with or what's been done since they've been coming to the clinic. So sometimes I go in and talk to the bio parents and just explain that the clinic works alongside CPS, but they don't work for CPS. You know, something that bio parents worry about a lot is that the clinic is reporting back to CPS on what the parents did, and that's not the case unless there's, you know, concerns. So that's something else that I've gone in and done, and that's been successful and helpful. Also just confirming information that caregivers provide. You know, sometimes if they think there's a home study pending on an aunt out of town and we want to follow up, you know, if it's a child with some more intense needs that we want to follow up with and make sure that that's the case so that we can prepare and help the caregivers in that transition. I'll reach out to the caseworker and say, hey, you know, foster mom said that he's moving in 2 weeks. Can you let me know what the plan is or whatever, and then follow up with the caseworker and share that with the medical team so that they can kind of react appropriately. So that's just a few things that I help with within the clinic. A few, there's a lot more. So how do we fix these communication issues? So I'm going to tell you some of the things that our team has found and that we worked through. Even when things are a little crazy like they are now, there's still a lot of good things happening even within our clinic. So I'm going to tell you about some of those. So we have to remember that we're all on the same team. It's very important that we keep in mind we're all on the same mission, but everyone has their own limitations, whether that's policies, procedures, you know, chain of command, whatever that looks like. You have to go by the restrictions within your agency. So you have to remember that the policies that apply to CPS don't necessarily apply to medical. So obviously confidentiality goes across everyone, but beyond that, it gets a little gray. So just being respectful of everyone's limitations and timelines, things like that, it can be hard, but that's an important thing to keep in mind when working across agencies. It's important to compromise and work within your realm of possibilities. You know, don't overcommit on either side of or guarantee anything, because we know in the child welfare system there's no guarantees. But within that, you can also get really creative. So I decided, I think that's like the unofficial motto of working in the child welfare system is how can we get creative and treat this child's needs, come up with resources, who they need to talk to, whatever that looks like. But you have to do that with having those conversations and following the policies of each system. So ultimately, the courts have final decision. So you can do everything you know, working as a team, you can do everything you can, have a big plan, everything's going well, and then they go to court. No one's communicated that to the judge or attorneys or anything, and then it's not going to work. So it's so important to have everyone on board, including the providers, especially attorneys, talking to those providers, finding out their recommendations and concerns. Medical, same thing, that everyone is on the same page, so that when you have those court hearings, everyone can make informed recommendations on what's going on with the child and their treatment. So one way that our clinic addresses these needs are through what we call care conferences. So this is a conversation where we bring everyone to the table, and we use this to address concerns, clarify, communicate permanency or placement plans, and to communicate recommendations. So this can be anyone. Anyone can call a care conference. This can be the caseworker can have concerns that they want to address. The medical team can have concerns that they want to talk to the child placement agency about. There's no limit to who can be involved, how many people, or who can call it, which has been super beneficial. And we've had them called by CPS, caregivers, placement agencies, whoever feels that there's a need. So this can include CPS, medical behavioral health providers, CASA, attorneys, case managers, school staff, and even bio parents. So these are just a few. There's a lot longer list. I know we've had kinship caregivers, lots of others involved, but anyone who needs to be at the table and in that conversation, it's so valuable to have everyone's input and answer everyone's questions directly, instead of having a lot of, you know, he said this, she said this, I heard this, I think this, I Googled this. We hear that all the time. So it's important to have these conversations and to give time to get that accurate information directly from the people in charge who are making those decisions. It also allows for some time for everyone to sit together and brainstorm. You know, how can we meet these needs? What do we need to do to address grandma's concerns? We want to make sure that everyone works together in those resolutions. So an example of this is we recently had a child who was recommended to have spinal surgery. She's placed with a foster caregiver who plans to adopt sometime soon. And she was frankly scared of the surgery because it's a very serious surgery. And she had a lot of hesitations, and CPS was concerned, you know, that they wouldn't be involved in the case when the surgery was to take place. And so they were trying to figure out how can we help this caregiver be comfortable to make this decision. So we worked with a team from the team that was planning on doing the surgery from another local hospital, and we actually partnered with them in this care conference, bringing them to the table, as well as the foster/adoptive mom, CPS, case managers, our medical team, whoever had been treating the child, to answer that caregiver's questions. And by the time she left, she felt much better about the surgery, and she was confident that that's, you know, what she wanted to do and to move forward. And it was really great, you know, giving her the time to express her concerns and what she was, you know, hesitant about, and then moving on from there. And everyone was able to support her in her decision and support her, you know, in the days to come and what that looks like. So that's a great example of how a care conference can be successful. So I highly recommend that when trying to communicate with CPS, community partners, whoever. So another really helpful piece is to know what and who is available from both sides, especially CPS. CPS has a lot of what are called subject matter experts. That's, at least in Texas, that's what they're called, who their role is to assist with outside agencies and address different issues. So I made this kind of word cloud to show some of the roles that exist within CPS that a lot of people don't know about. And so a lot of these great people can help navigate like we said, what can be a very confusing system, and help caseworkers, help medical providers, help behavioral health find resources for the child to meet their needs. So this is a pretty extensive list. There's a lot more. So it's really important to just communicate with your local offices and find out what's available, because all you can do is ask. I actually put foster care liaisons on here as well. In Texas, each school district has a foster care liaison assigned. It's a very difficult list to find. You have to kind of navigate through the education website a little bit, but it's there, and they're there to help with children who are involved in foster care to make sure they're getting the services they need in school. So that's a really great role that exists outside of CPS that's also super beneficial to both medical and CPS, and having those conversations to make sure everybody's needs are addressed. So in addition to that, it's also important to have a connection. So within our clinic, I'm kind of the connection, and then my partner who's in the Plano campus is kind of the backup. But even outside of that, we still have our connections within the CPS offices who we're able to contact. If you can't get in touch with someone, you don't know who to get in touch with, it's so important to have someone within CPS and the healthcare, agencies that you're trying to communicate with that you can contact directly and say, hey, I need to get in touch with this person. I'm trying to find out about this, whatever that looks like. Like I said, resources are nearly always available, and you have to ask. An example of this is ABA therapy, which we know gets recommended all the time, but is not covered by the foster care insurance that, at least in Texas, that covers every child who's in foster care. So one way it can be done, but it has to go through an extensive system, a lot of approvals. It has to go through state office. So in rare cases, it can be done, but you have to ask. You have to go through the appropriate channels, the appropriate approvals, the appropriate denials, but it can be done. And so that kind of goes back to that get creative piece that I talked about. You have to do what you have to do sometimes. And so knowing who to talk to, we have a contact person at the insurance agency that helps us with this. So that's a big part of knowing your resources. So along that, don't be afraid to work your way up the chain. Caseworkers are busy, doctors are busy. So email is probably the best way to get in touch with most people. And if that doesn't work, I usually give caseworkers a week. And then if I don't hear back, I email them again, and I include the supervisor. Then you usually hear back pretty quickly. And I haven't had any issues in that way, but don't be afraid to work your way up the chain. There's nothing wrong with that, especially if you have concerns or issues that need to be addressed pretty quickly. It's fine. Just email the supervisor. Caseworkers, there's a lot of turnover, so it may not even be the same caseworker that it was a week ago. So it's important to kind of keep track of that. Along those lines, organizational charts are available usually. So that's another piece of having a contact within the office that you can reach out to and say, hey, can you tell me who so-and-so's supervisor is? Can you tell me who, this is an example of my personal unit, but knowing who to contact within that. If you can't get in touch with someone, who's someone else that you can talk to get your concerns looked at. Another piece that we found when talking between systems is not to use internal or field-specific acronyms. That's a huge piece. Medical terms are difficult if you don't speak them every day. Sometimes even if you do, I hear them all the time and I still don't know what half of the things mean, but I ask, and that's helpful. So even within the CPS side, there's a lot of terms that we use that don't transfer over to other agencies. So we're all guilty of this. We do it all the time just because we get in the habit. But when you're bringing other people into the conversation, it's important to make sure you address that. So I listed a few of the CPS terms that are used here in Texas. Some of you may know what these are, but that's just the example of, that there's family-based safety services, FBSS, conservatorship is CVS, on and on. And this just creates further divide. If you have people who don't understand what you're talking about, if I say grandma has PMC of him and someone doesn't know what that means, that doesn't communicate any information. So this goes across the board, especially when you're talking with caregivers and children, especially older children, when you're trying to, have those appointments and things like that. You want to make sure that you're using plain terms or that you're explaining what you're talking about and then, reiterate understanding throughout the conversation. From the CPS side, I put an annual refresher helps. So every year I do, at one of our staff meetings, I give a CPS refresher where I go from removal all the way to return home, of the timeline, all the things, so that our staff knows what some of these things mean when our team comes in to see the kids, that they know what the child's talking about, they know what the caregivers are talking about. I'm on site, that I can always answer questions, but it helps to have that refresher of like, okay, this person is still in investigations. I know what that means. I know what's next. So that's also very helpful. So this kind of goes without saying, but we're going to say it. So just be respectful of others' time and efforts. Like I said, everyone's doing the best they can. They're working as hard as they can. So just keep that in mind, because everyone's busy with professional and personal lives. So, you know, I always have to remind myself that my email may not be the most important thing going on in that person's life that day. And so to give people that grace of like giving time to get back to you. If you're trying to get in touch with the medical side, don't call the day before and expect a full report, or the CPS side. Everyone's busy. If you need to make an appointment for a phone call, make sure they get an email, whatever that looks like. That's a good idea. Especially scheduling an appointment during doctors, therapists, whoever, their admin time, and then making sure that they have the appropriate paperwork beforehand. So that's either court orders, like if you're a court, like a CASA assigned, at our clinic, you have to send over the court orders beforehand. And then that way that speeds things up. You don't delay the call because you're waiting for orders, things like that. Or just a release of information, which is, you know, can be signed by the caseworker or whoever's involved. Excuse me. So again, caseworkers are also all over the place. They're in court, they're driving around, they're seeing kids, they're doing paperwork, they're very busy. Again, it's fine to work up the chain, but also give them some grace of taking some time and, you know, not calling them. Emergencies happen, but usually there's something that can wait, you know, till the next day or whatever that looks like. But at the same time, it's important to follow up on either side. So yeah. So our takeaway, that we have to collaborate and express and address concerns in a timely and respective way, to allow everyone to play their role in working towards the goals and in the child and family's best interest. So yeah, that's the biggest thing I hope we've talked about. It's just letting everyone do their role, but collaborating together on how everyone can do their role to work together in the child's best interest to make sure things get addressed and that nothing gets missed. Okay, so we'll talk about some questions. Here's my contact information. I'm always available for questions. This is my dog. I had to include her because she's the best. So yeah, so feel free to email me. That's my office number, so I'm not there right now, but you can always email me if you have any further questions or want to learn more about our center. So that's it from me.
Thank you, Erin, and we will give you a few seconds. And if you have questions, you can open the mics or you can write them on the chat. Thank you, Erin. It was very interesting. Thank you.
Yeah, thank you.
And I must say that I really love the video about your center. And I was wondering, how can we watch it? Is there an access in your website to watch the video if I want to watch it?
Yeah, that's on our public page. So it's just childrens.com/fostercare. And it's at the top, and there's a little YouTube link that says watch video or something like that. So yeah, it's on our public page. and you can watch it anytime. We're pretty proud of it. So.
Great, thank you. Thank you. I wanted to show my colleagues in Israel, because in Israel, we do not have special clinics for foster care. And this is so necessary, I mean, to have this place that gathering all the professionals that understand exactly what a foster care is, and the kid and the families. So it's such an amazing.
Yeah, like I said, it's a super unique environment. I know, like I said, we have the Plano campus. I know in Fort Worth, which is pretty local to us, they're working on getting a foster care clinic going. I know in Houston, they're working on one. So the bigger, metroplexes have something they're working on. But even those, ours is one of the only well-established centers in Texas. So it's a really unique environment, but you're right, absolutely necessary. I see.
Yeah, we have two questions. Yeah.
Yes, I can read the question.
Okay.
Do you work with MOUs in your coordination or releases of information?
Right. So since we're under the hospital system, I can release what we call the after visit summary, which is just a summary of the child's appointment from that day, but anything beyond that has to be requested from the medical records department. So in terms of releasing records as a whole, it has to be requested formally like that. But just for providers to talk to each other, we use releases of information, and that has to be signed by either the caregiver or the caseworker. Either of those two can give permission, and then we just keep those on file. So yeah, we usually use the ROI.
Okay, so if we don't have any other question, we will say thank you very much to Erinne for joining us this afternoon and share this important knowledge with us. Thank you so much.
Yeah, thank you so much.
And have you all a great afternoon.